Ah, it's quiet, so I know how to get everybody to quiet down and just feed them. Right? So, welcome and good morning. My name is Dr. Scott Roth. So I'm the founder and CEO of IMCOR. And I come from the cardiology world, and have been fortunate to spend some time here learning from my trauma surgery program manager colleagues. I really wanted to just say just a couple of words before I introduce our speakers here. Congratulations to the entire group, not just our speakers, but I can tell you in traveling and visiting hospitals all over that you guys are doing a great job in showing the world what quality improvement really looks like. And it's really a great example, and we can learn from it. So today we're here to highlight really a successful team, if you will. And I think the team aspect of this is highly important, and that's why you guys are here. Because it's not just about individual clinician or the individual patient, but where is the opportunity for process improvement, and in particular in some areas, is it possible that in our trauma resuscitation and hemodynamic management that there really is an opportunity to affect some of the most important quality metrics. And so with that, we have here two leaders, essentially, in trauma quality improvement. And so the way that we'll structure this today is I'll have both Dr. Ashley and Tracy Johnson speak, and then we'll hold some time for questions after that. I think it might structure our conversation a little bit better. But really, we'd like to open this up for an exchange of ideas, if you will. So feel free to engage and ask your questions, and we'll have a conversation. So with that, I'd like to introduce Dr. Dennis Ashley, who is the chair of the Department of Surgery and the director of trauma and critical care for the medical center, Navicent Health in Macon, Georgia. And subsequently, Dr. Ashley will introduce Tracy.
Thank you, Dr. Roth, for that introduction, and thank you for being here so early in the morning. I think anyone that shows up, if this were college, anyone that just shows up at this time of the morning gets an A for the class. So there will not be any pimping or any questions to the audience, so you can relax. So we'll take a few minutes, and my goal today is not to go through all the literature and tell you where this fits in. I'm really just going to get into really the nuts and bolts. It's really sort of a very practical talk, and then you can ask me any kind of question about the literature you want to at the end. But what I'll try to do is really just give you just a very brief, because I know there's some people in the room, that's probably why you came, you don't really know what this is, you've not seen this technology before. So I'll give you a few slides on what it is, and then very quickly get into 4 cases that I do, or that we've done, and just show you how we use it. And so this is sort of how the morning will go. What is hemodynamic ultrasound? A very brief review, talking about 4 cases. Then Tracy will talk a little bit about institution and statewide PI, and then we'll have some time for questions. So here's the problem, just very quickly to introduce it. I think everyone in this room realizes that. It's a constant change, hemodynamic monitoring, or where your patient is on this curve. And your patient may jump around on this curve. So what was good today or what was good last hour may be different the next hour or the next day. So we want to make sure that we get the right amount of volume in our patients. If we're too restrictive, you see the things that can happen there, hypervolemia and so on, renal failure. If we're overzealous, we know what happens there with the tissue swelling and the open abdomens and compartment syndromes. We've gone that route and we've learned a lot from being overzealous. So where is that sweet spot? And if you had to remember one thing from today's talk, the sweet spot is really what we're trying to achieve. How do we get there? How do we find euvolemia? Well, a lot of people know about TEE, transesophageal echocardiography. I'm sure Dr. Roth, being a cardiologist, has done a large number of those. Very fancy. I'm sure everyone in this room can order that test in their ICU or in the OR. This is one of our cardiologists in the operating room with our cardiothoracic surgeons. They're probably doing a valve or some type of cardiac procedure, and he's providing real-time TEE support to the cardiac team. But in the ICU, I can order that test, but that doesn't really help me to order that test and then tomorrow to get a dictation, or maybe a couple of days later to tell me exactly what that shows and what the valves are doing. What I really want to know is what's the heart doing at that particular time, and what is the volume of the patient. So TEE for me is okay, but it doesn't help my needs at 2 o'clock in the morning or on daily rounds. So then the last few years, we started hearing about this HTEE, or hemodynamic ultrasound. And you can see here the two probes. There's Dr. Hudson on your left with his very fancy TEE machine that has crystals that can spin things and do things and tell you about valves and just all kind of wonderful things. It's very sophisticated. And then you have our less sophisticated, I'll say this a little bit fun, one of our surgeons, very less sophisticated than a cardiologist, Dr. Roth. But that's why we went into surgery. We weren't that smart. We couldn't figure out how to flip all those valves around and everything on the crystals. We're having a little bit of fun here. But anyway, Dr. Christie, you see with a very small probe there, it's about the size of an NG tube. Can go down and stay for 72 hours in the esophagus or stomach, and is placed just like an NG tube. And what that does is give us real-time ultrasound. It's a very simple ultrasound, if you will, and I'll show you some pictures in just a minute. We drop this probe, we say, in the ICU. And you see on the far left there's some indications. Hypotension, hemodynamic instability, shock. Really, the way to think of that for you in the room that are old enough to, when we used a lot of swans, every ICU patient has Swan-Ganz catheter. It's very similar indications. If my patient's hypotensive after a reasonable volume resuscitation, I wouldn't just, anytime somebody drops their blood pressure, I don't just drop a probe. But if I've given them fluid volume resuscitation with crystal order blood, they don't respond appropriately, or it's continuing. If I'm escalating pressors or starting pressors, I'm on the ventilator and I'm not sure where I am hemodynamically. When I start to get into these sort of loops, then I start thinking, do I need to go to the next level and actually monitor what I'm doing? Once you start monitoring, you see it's continuously available. You're looking at 3 different views. I'll show those in just a moment to see where we are volume-wise. And then we start tweaking things. Do they need more volume? Do they need pressors? Do they need inotropes? What does the patient need? And then once I make an intervention, I go back and look at the pictures again to see where I am. In the old days, that would be going back and shooting a cardiac profile to see what your SVRI is and your cardiac output. And then the goal is to, as we move through that process, to optimize cardiac performance and improve outcomes. So here's the 3 views, and just to, this, to me, when I was learning to do this, this was really the one slide that I paid attention to. All the other stuff I didn't really care about, because basically, if you're a surgeon, you really focus on the anatomy and what the pictures are. So before you can start talking about ultrasound, before I can show you a video of some hearts beating and vena caves and things, it won't make any sense if you don't know where you are. So there's just 3 views. You see the top view there. The probe goes in the esophagus, just like an NG tube, goes down into the stomach, and you see there's a gentle curve to the tube on the handle. I can only turn my handle 2 directions, forward and backwards, so I'm going to curve that either forward or backwards, antegrade or retrograde. And you can see I'm shooting an ultrasound beam through my stomach, through the heart, and on the left there you can see what it looks like with an ultrasound. It looks like a donut. I'm seeing the wall of the ventricle. I've cut the heart in half. I'm seeing the left ventricle. And the stuff in the middle, the black stuff, is blood or volume. And the gray, whitish area around it, the donut, if you will, is the ventricular wall. And that's the cross-sectional area of the heart. So if there's a lot of black stuff, the heart's full. If there's not a lot of black stuff, the heart's flat. It's not that complicated. If the heart's beating really fast, it's hyperdynamic. If it's not beating real fast, it's not hyperdynamic. So very simplistic, that's the way I look at it. The next slide, I pull the probe back just a little bit, just about the GE junction, and for those of you that do endoscopy, that's about 40 centimeters from the incisors. So as I pull the probe back a little bit, on the second picture there, angle it down a little bit, you see my blue wave shooting through there, and I get a 4-chamber view. And then if I pull it back just a little further, I can see I'm shooting right across the aortic root and the superior vena cava, and you see the SVC labeled there, sitting right next to aorta. If that's big and fat and juicy and doesn't collapse every time the ventilator fires, then it's full. That's good volume. If the walls are kissing and it's really floppy together every time the ventilator fires, then the patient is flat. So again, very simple ways. We just want to know, do I need more volume or do I need less volume in the ICU? So now with that introduction, let's go through a few cases to show you what I'm talking about. And this first case is a gunshot wound to the chest, had a thoracotomy, had a lobe resection or a wedge resection, and remains on the ventilator with APRV. We were about 4 or 5 days into this now. It was time for this patient to start immobilizing. This was a young patient. There was no reason to think they'd have kidney failure. They were very swollen. And so it was about time for them to start really mobilizing that fluid. And so I was convinced, this is one of our earlier cases, and this is one of the cases that really made me start to think as I started to use this technology that maybe we were onto something here. And I walked in the room, I saw the patient like I'd seen 1,000 patients like this before. Anasarca on the vent, APRV, was having trouble oxygenating. They were really seeming wet to me. And so I told the resident to give some Lasix and we would help this patient mobilize their fluids. And the resident I was with at that time was very sweet, about a 98-pound, female resident, just very soft-spoken. Said, on her first rotation in the ICU, so really a novice at ICU care, said, Dr. Ashley, I really think maybe we should just drop a probe and look at the hemodynamic status. And I said, no, you don't need to do that. It's okay. They're swollen. They just need Lasix. So I walk out of the room. She comes back to the nurse's desk. She said, Dr. Ashley, I really just feel like we need to take a look. Very soft-spoken. I said, okay, you can take a look, but it's not going to show you anything. We're just wasting money here, because those probes, we don't need to use a probe if we don't have to. And she said, why don't we try it? And I said, okay, let's try it, but it's going to show that the patient's overloaded. And so what we found out was that actually the patient you see on your left there, that's a hyperdynamic heart. You can see how the donut, if you will, or the ventricular wall is really contracting hard. You can see how the walls, when they come together, and diastole, the actual ventricular walls are kissing, what we call kissing together. So they're really ejecting all the volume in the heart, or most of it, because they're hyperdynamic. And so basically what that tells you, I won't go through all the pictures, but that tells you that the patient is dry. And so we ended up giving 1 unit of blood instead. And you can see on the right there how less hyperdynamic that heart is. They're not fully resuscitated yet, but we're moving in the right direction to where now the walls are not quite kissing all the way together. It's less hyperdynamic. And so the patient needed volume, even though they looked overloaded on the ventilator. And this is just to show you, you might say, well, I'm not really good at looking at things like that. So can you give me some measurements to look at? And the answer is yes. You can see here, you can freeze frame that, if you will, and draw a little circle around it. You see on the left, we've drawn a circle where we've frozen the picture, the image, and you can get an area. The machine will calculate an area, and you see up there it's 6 centimeters squared. Basically what that means, you would like, at the end of diastolic volume, you'd like to have that over 10, okay? If you want to stick a number, you get to the point where you just look at these and you make your decision very quickly. But if you're a numbers kind of person, there is a number you can remember. When you draw that out, or the computer calculates it for you, the number is 10. So if they're less than 10, you would think they would be volume responsive. If they're over 10, they should be euvolemic. Now again, we don't focus just on numbers, like if it's 9.9, I don't go give a liter of fluid. But these are just some general things to put in your head. You also want to go with clinically how the patient looks. And you can see our patient was about 6 when we ran the numbers on the patient here. On the right side, we did the same thing after we gave the bolus, and you see our left ventricular end diastolic area has increased to 8. So we know we're moving in the right direction. So the second case, this is a little bit different. This was a successful laparoscopic appendectomy. really following the acute care surgery model here. We'll throw in an acute care surgery case. Demonstrated some ST segment elevations on EKG in the recovery room. Managed with supportive measures and observed on the floor with telemetry. And then post-op day 2 demonstrated only a mild elevation of his cardiac enzymes and troponin values, but developed respiratory distress, oliguria, with mild rise in his creatinine, so he was intubated and transferred to the ICU. And this is what the chest x-ray looked like. You can see, based on that history and with that chest x-ray, this guy, you would think needs Lasix. They're overloaded, okay? There's no way you would give this guy that's having cardiac issues this kind of chest x-ray volume. So it appeared to be cardiac failure and volume overload. But this is what we found when we dropped a probe. You can see on the far left, you're starting to see now that ventricle is not dilating up during systole. It's not very full. It's hyperdynamic. And if you look at the middle picture there, if you look at the middle picture right here, you can see that vena cava. See how it's collapsing? The walls are white and the blood is black. So you see how those walls are really hammering or kissing together. It's just not very full. And if you look at the 4-chamber view here, you can see this right ventricular wall. Here's the right ventricle, septum, and left ventricle. You can see how this wall is really coming in and collapsing. It's just not very distended. And even the left ventricle is not very distended. So much to our surprise, this gentleman was volume depleted. Remember, he's not making urine either at that point. So then with some, this is after about 4 hours with some volume resuscitation. Now you can see here the ventricle, the walls are not kissing together at the end of diastole. We still have some black stuff, if you will, in the ventricle. Look at the vena cava now. Remember how the walls were really kissing together? Now you can see how they're staying open. That vena cava is full. And then if you look here at the right ventricle, you can see this wall really during diastole is staying out. It's not coming all the way in and kissing the septum. The left ventricle is fuller too. So again, the patient needed volume. Case 3, this is your typical trauma patient. I'm sure y'all see every day. Everybody's got one of these. You know, the guy with the trifecta, got a 58-year-old male, 2-car head-on MVC, some tachycardia, complaining of left hip pain. You see we got on CAT scan a small sling laceration, non-op, complex left acetabular fracture with some hematoma down there at the bottom, and then a tib-fib fracture. Pretty much is, you know, a patient that we see on a frequent basis. So they go to the OR, received 2 liters of crystalloid in the trauma bay, ORIF tib-fib fracture, intraocularly still some tachycardia, heart rate in the 120s, blood pressure in the 90s, lactic acid is up. You see anesthesia, gave a couple units of blood, 5 liters of crystalloid, 2 ounces of bicarb, and you can see there, you know this is an ortho case because the blood loss was 120.